everybody. This is Judy Thompson, the Director of Clinical Education at the Association for Vascular Access, and I'm welcoming you today to the I Save That podcast. And it is officially fall, and that means it is conference time. This podcast is brought to you by our sponsor today, Covalon. Joined with me today, I have Michelle DeVries and Dr. Jack LeDun. I'm so excited to have these guys here to talk with you, talk with me, and hopefully you'll find it informative and a little bit entertaining. Without further ado, I'd like to bring them onto the show. Welcome, guys.
Judy.
Hey. John.
Hello, everybody.
Hey, Jack. Thank you for being
glad
here.
to be on. Glad to be on.
So we tossed around quite a few ideas for this podcast today. And Jack, I'm going to let you lead the pack. What when you go around in hospitals, and I know you go all over the world, all over the country, and you go pop in hospitals, whether you're invited or not, and you go see what's going on. You round in the ICUs with docs, and tell us a couple of the things that are generalized across every hospital you see that need to be improved.
I'll be glad to, Judy. Essentially, there's a uniform set of findings to the point where I feel I can tell people what goes on in their hospital without having to go there anymore. And I'll put these out there, and you guys tell me if it resonates. So basically, and these aren't the hospitals that have vascular access board certified people in them or in charge. It's kind of like, it might be big name institutions, famous places, but I've found that the hospitals have underinvested in vascular access. And this leads to, four uniform findings. The number one finding that I see is that nobody's in charge of vascular access. In other words, if you walk into a hospital and you say, who's in charge of infection prevention, they would send you someplace. If you said, who's in charge of surgery, they would send you to the Department of Surgery. If you say who's in charge of vascular access, it's like, no, they won't know what you're talking about. At the front desk, they will not know what you're talking about. And because nobody's in charge, it leads to unsupervised residents performing suboptimal procedures with outdated equipment. Uniformly, we find that. And that is not the way forward. And then next thing, and surprisingly, they have a CLABSI problem with the, with the unsupervised residents, not doing it. I mean, so I was in one hospital and I was trying to get an intern. A fellow was going to do a procedure and I was going to proctor him from outside. And I tried to get the intern to scrub in just to get, what little experience you can. And the intern told me, Dr. LeDun, I'm good. I've done this 12 times. So I was going to tell him, I've done it 12 times a week for 15 years, but I figured I'd be the crotchety old guy if I said that, you know what I mean? And, but the intern said to me after we go, hey, I can really see the value coming from the side of the bed rather than the head of the bed. So he learned something by watching the procedure, but he wouldn't scrub in. But that is the number one finding, that nobody's in charge. Nobody's in charge of vascular access. And you can imagine what flows from that, not having somebody in charge. And their equipment becomes 20 years out of date. A lot of time I find, the first description of the jugular vein that usually we say it's attributed to Dr. English in 1969. What I find that jugular vein practice is 1969 plus ultrasound. They're really practicing. They go to the head of the bed, they put it in the middle of the neck, direct it upward, suture it down, and they used ultrasound to puncture the vein. It's really like 1969 plus ultrasound. It's and then hey, we have an infection problem. Yeah, hey, strange that, strange.
What have you seen, Shell?
I agree with Jack, but I think it's broader. Jack took aim at the medical staff and the residents. But I think there's a much broader concern about who's doing vascular access and what's their training throughout the continuum of care, starting pre-hospital through everything else. So yes, what you're seeing with residents, I think, is not
Right.
completely unusual.
But
But
let me interrupt. I'm not going after the resident. It's that they're unsupervised. It's not, I am not, where our job is not to blame the residents, to train the resident. But go ahead, you go.
oh, that's beautiful. And that's what we're addressing right now with pre-licensure. And I know Judy can go on this forever, but with the PIV curriculum, because that same practice is being echoed in healthcare around the world right now, with untrained, unsupervised staff accessing veins and doing the best they can with whatever tools they can find. So I love it because that is a tie-in to a really big initiative with us at AVA right now, which is standardizing the education and the expectation before anyone even starts touching a patient, and that starts in pre-licensure.
The novices should not be trained by Novice Plus.
Oh God, no, you're right.
The novices have to be trained by experts. You know, like everything that flows after that, if you don't have proper training, you know, is what you get. Shall I go on to number 2 finding?
Yes, please. What's your number 2?
All right. Number 2 finding is, now, CLABSI is a surrogate for the quality of vascular access in general. It's a really good surrogate for that. I mean, it's not just CLABSI. It's like you have a CLABSI problem, you have a vascular access program problem, or you know what I mean? Like, I think there's a strong correlation between the two, right? Hospitals that want to improve their CLABSI, this is Jack LaDunn, number 2 on the list of 4. Hospitals that want to improve their CLABSI always start by trying to fix care and maintenance. It's uniform. Like, oh, we try, you know, we changed the dressing. We did this, you know, it's care and maintenance. And do you know why? Do you know why they blame care and maintenance? Because the bacteremia is picked up on day 5. Hey, no anesthesiologist in the world has ever accepted responsibility for a CLABSI because it's not related to the insertion because it came at day 5. But if you put that thing in a way that the dressing won't stay intact and the nurse can't handle it, then it is on you. It is an insertion related problem. These things are related. Like, that's the part I would say my thing is the relationship between the insertion and the care and maintenance. If you start by blaming care and maintenance, now another thing is blaming care and maintenance is blaming the nursing staff. They don't say that. The hospitals don't, they're not naive enough to say that, you know what I mean, to get the nurses all riled up. But when you're blaming care and maintenance, you're blaming the nursing staff.
I want to say
Shelley?
2 things to that, Jack, if I may. Care and maintenance absolutely comes up a lot, but I hope before anyone goes to care and maintenance, they're doing an evaluation and investigation of the case and that there's something pointing them there. Because certainly, yes, if we look at intraluminal versus extraluminal routes of infection, there's going to be a time when we're saying it is more likely care and maintenance. But I take what you said as an absolute truth and something that is often ignored, that even though it is not an insertion technique related infection, it still can be inserter driven. If you've made a poor site selection, as you've talked about, if you've placed it in a manner that it can't be secured and stabilized and dressed, or if you put in 3 lumens when you only need 1, you're still part of the problem.
We'll get that's number 3.
Oh my goodness.
Number 3 on my list is many institutions have 1 central venous catheter. It's usually a triple lumen, 20 centimeter catheter. That's the only one in the institution. So I'm going to let my infection preventionist, molecular biologist talk to what is the infection prevention ramifications of only having 1 catheter. And Shelley just, talked about the lumens.
Well, my concern with that is not having the right device for the patient's needs, right? You're making a guess based on what you have available to you, and you're not going to optimize what the patient needs. If we're putting in more lumens, we're requiring more care and maintenance, more medication, greater risk of DVT, greater risk of infection, and nursing time. So it
plays back to nobody's in charge. So you know what happens? Purchasing becomes in charge. You know what I mean? Infection prevention wants more catheters. Dr. LaDunn wants more catheters, but nobody's in charge. So purchasing just gets that 1 catheter. Nobody in the institution knows enough that they need single, double, triple. They need the patients. usually the patients come in different sizes. And
Yeah,
so
what if
should
you get
their
the big
catheter.
boy in? What if you get the big boy and have to
Like,
go to the left?
So there's another ramification to it. They don't really care about tip location, because the point, the case you're bringing up, which goes on in every hospital every day, they can't get it there.
Right.
So it tells you that the infection prevention ramifications of having more lumens than you need is there. The not being able to get it at the cavoatrial junction is, they don't really care about this stuff, you know? So like, purchasing has become in charge. I think we should start hanging Clabsies on the purchasing department and see what happens, you know?
But you know,
So
you can get you can get another 1.5 centimeters if you hub it though, Jack.
Definitely. And you can even indent the skin a little bit. I mean, you can you can get the skin in those big people down at maybe a centimeter. Well,
can we
if you're going to make an incision, sure.
Here? This is not an actual recommendation for safe patient care.
No,
but they don't care. So
I
mean, these are red flags. When I go into an institution and they only have one catheter, it tells me they don't really care about the tip, where the tip is. They'll tell you cavoatrial junction because they memorize it, but they don't live it. If you only have one catheter, they're not living that the catheter has to be in the right spot, because a lot of times, Judy, in the case you mentioned, it'll be pointing into the wall, you know, of the SVC, the top where the brachiocephalics come together. All right. So number one, nobody's in charge of vascular access. And there's a whole cascade that comes from that. Number two, they always start with blaming care and maintenance to fix their Clabsy problem. And sometimes the light bulb will go off like, hey, bozo, what'd you put it in like that for? Like, until you have to fix insertion first if you want to impact your infection rate. So the third thing is that they only have one catheter, and it's just a red flag that they're behind the times, 10 years, even 20 years, right? Shall I go to number 4?
I would love to hear 4. Or Shelley, do you have something on?
Yeah, I have a question, Jack, because I think the concept of who's in charge of vascular access, particularly on the medical side of things, where we have teams in many programs who aren't yet able to place all of their own devices for a number of reasons. And you've had an opportunity, I think, to be a medical director over a variety of different programs. In the absence of someone having a Jack, is there a service that you feel is a good target for people to start to work with, to have those conversations with their medical staff, even if someone is not the title of medical director of vascular access? But where would you have people start if they're faced with that very basic but omnipresent challenge in their organization?
The only 2 systems that I've seen that work or that I like are, number one is a strong director of vascular access that can put in, you know, the peripherals and the centrals. And the second one is a strong nursing vascular access team that wants to move into the centrals. And they're not mutually exclusive, but those are the only 2 systems I've seen that really get to modern practice, where you'd have more than one device. You wouldn't be blaming care and maintenance if the insertion's a problem. Like, those are the only 2 systems. One is a strong director of vascular access. And I'm not saying what his degree is or what, you know, his or her, you know, credentials are. And the other one is like when they have a great skill set from the peripheral and they can move into the central and they know this stuff. They've gone to the AVA conferences. When I taught, like, you know, the AVA conference, the national, and also the networks, there's nothing like that for physicians. There's really no graduate medical education in this thing for physicians. It's really bad. So, Shelley, go back to so where would you start? I think that it's a very interesting question. And so we have a strong nursing team that wants to improve vascular access in their hospital, and either take on the centrals or just improve things in general. So they have to find, it's different in different hospitals. Sometimes it's pulmonary critical care. Sometimes it's surgery. I mean, IR, I don't like IR because they don't, you know, they're stuck down in the, I mean, I love them. I've learned a lot from IRs. And I don't agree with, they don't agree with me about the axillary vein. So, it's tough, tough.
I think Mary
I think
Constantino agrees spot on.
with me and Trerotola. Oh yeah.
Yeah.
I think Mary Constantino's got Trerotola believe everything I have to say about vascular access, pretty much. Unless I got it wrong, unless I got those
Nah.
debates wrong, So you have to find your guy, you have to find your person that's interested, knows something about vascular access, and is willing to go to bat for you over the issues. Does that answer your question, or Shelley?
The one thing I would say is, you said there's not a place for these docs to go. I would say there is. Yes. Hello.
Yeah, no.
Our network,
so
we need to do a better job, though, of reaching out, welcoming, and picking topics and speakers who can address that.
And I think they won't even show, but that's what you can do. That's what you can do. You can have like a program that's in their sphere that they would be interested in, and then hope that they would show up. I mean, many times. How did we
get you? How did you get so entrenched with us?
I got a copy of the journal at work. It showed up, and I'm leafing through the Java. It had a different name back then, and I'm leafing through, and I'm going, boy, this sounds a lot like what I do, So instead of putting it down, I got to a thing where, join the society. So if I put the magazine down, I would have never found it again, because I don't keep my office that neat. And I joined, I saw a thing like, hey, submit your ideas for our conference, so I submit my idea. Next thing, a lady named Darcy calls me up, and says, well, you got to do, can you do another topic the next day? I go, well, it's probably the same topic. Yeah, anyway, that's how somebody sent me somehow I was on a mailing list, and somebody sent me the journal, and like.
How lucky for us.
That's how awesome. Lucky for me. It changed the trajectory of my career. Getting that thing in the mail, it changed the trajectory. You know what I mean? Because I always viewed myself as like a vascular access orphan with an ultrasound machine. I didn't know there were other people like me. I didn't know that. Then when I came to AVA, I met my tribe. And it was,
isn't that the story we all have? I mean, many of us that same way, coming to our first AVA and going, oh my goodness, I have found my people. Right. I didn't know you were out here. And to be embraced and supported and find like-minded folks just passionate about this.
What a great plug for our conference, right?
My first one was a show. Mine was a show.
Your first one?
Yeah. It was like, it wasn't love. It wasn't what it, it was like, who's this guy? There was a lot of. But,
that's amazing. Okay, guys, I'm going to leave you at the edge of your seats for a moment while we hear a word from our sponsor, Covalon. This scenario is about Emily. She's a NICU nurse. The number of patients she oversees is higher than ever. She's already feeling burnt out, and the rise of CLABSI is not helping her stress. Her tiny patients constantly tug at their IV lines and drool on the connections, not to mention the occasional contact with a dirty diaper. Emily can't monitor her patients 24/7, but the stakes of even a single CLABSI are very high. Then, Emily's unit started using ValGuard, the world's only transparent vascular access line-to-line connection barrier with quick release. Now she has some peace of mind, knowing that her little one's line connections are protected from external contaminants when she's not around. And because ValGuard is transparent and has a quick release pull strip for easy removal, she can access the lines when she needs to. Do you want that peace of mind with your patients? Protect your catheter hubs and line-to-line connections with ValGuard. Learn more at covalon.com/CLABSI. That's covalon.com/CLABSI. Or visit Covalon at this year's annual AVA conference at booth 607. Now back to the show.
All right, number 4.
Okay, number 4.
Number 1 is nobody's in charge. I mean, like, whatever you get after that is what you get when nobody's in charge. Number 2 is they always start by blaming care and maintenance. And, people listening to this, tell me yes, tell me no. The third thing is they only have one catheter. Like, these are red flags. The fourth thing is the acute hemodialysis catheters always have the worst infection record.
They do.
And the reason for that is the way they're inserted. They put it in poorly, like in the middle of the neck, directed up, but then it's got these curved tips instead of a curved body. It's curved tips to keep it out of your ear canal. It's to keep this out of your auditory canal. But then, like, not one time in the history of planet Earth has this thing, the dressing, stayed intact if you put this thing in and direct it upward. But to fix it, this is lipstick on a pig. Having curved tips like this is lipstick on a pig to me. Those are the four things that I find routinely when I go to an institution. And people listening to this, tell me if I got it wrong.
I don't think
Tell me if I made it up.
The other thing that really frustrates me, I think IOs are vastly underutilized. You see all these really crappy central lines going in the groin during a code situation. And it's usually a junior burger trying to do it because they need their practice. It's terrible, terrible practice.
Well, McKella dealt with it. McKella at Johns Hopkins, they took the central line kits out of the class.
Brilliant.
You can only, I mean, like, hey, I've done many lines in that circumstance when somebody's crunching on the chest. It's not a happy situation. You know what I mean?
Not for anybody.
It's fraught with bad results. You know what I mean? But the intraosseous is certainly the answer to that. My mission to fix those four things. Like when you bring me, if I go into a hospital, those are the things that are either going to get fixed or I'm going to go out. One of us is going to go out crying.
I'm going to change gears just ever so slightly. I want to talk about skin injuries and dressings. So we've got all these fragile skin folks out there. They're either prednisone skins, they're just older, fragile skins. And fragile skins, that sounds odd. They're older folks with fragile skin. And we have a really hard time, one, keeping a dressing on them, but two, if we keep the dressing down, we can't get it off without ripping their skin off with it. And what kind of strategies do you think we could use for some of these patients that we can keep a dressing down, not rip their skin off, and also not create an infection based on predisposition for skin tears? What do you think?
So in my unique role, which I always need to remind people, I am not a direct care provider. I'm an epidemiologist who studies this ad nauseum. But with all of our work on dressings, we involved our wound nurses from day one when we began trying to work on improving it. So a lot of what we learned and did was at the direct guidance and involvement of them. But what I've learned through my rounds and our studies is our practices, like so many others, really stand for improvement. And so technique, low and slow, there should never be a ripping. And I think we get frustrated and we go fast. And we have become strong advocates of adhesive removers. There's a lot of different options out there, but use them liberally with any time we have adhesive products. And as we've looked to improve our dressing integrity, it's coupled with liberal use of adhesive removers for our patients, and realizing that our current practice of continually having dressings removed and replaced is also stripping the skin further and creating further concerns for our patients than finding a way to keep that dressing on as long as possible. Doctor?
Is there a way to keep adhesive products from going on in the first place, or, like, in other words, wrap them with, Covalon or wrapping, like gauze, like just keep adhesive. You can see those skin, it's purple, there's blood, there's hematoma, like there's ecchymosis there many times. Is there a way that we can keep adhesives off of those patients?
So I was to say, clinically, obviously, it's not something I can offer a suggestion on. I know people have done exactly what it is that you're suggesting, Jack. My concern is always out of sight, out of mind. And when we look at the frequency that these devices need to be assessed, and it's a laying on in the hands and an inspection of the site, when they're all wrapped up, and for good reasons, they're wrapped to keep it on, making sure that the staff caring for that device are still doing a thorough and frequent assessment so that we're not exchanging one risk for another. So that's my caution when we go to completely covering the site with a wrap like that.
Yeah, but, I agree with Shelley. I think essentially all adhesives should be removed with a solvent, with an adhesive remover. I mean, like for my family, and I've taken off so many dressings, and I've got one where, I took off the skin with it. It's like it was a stat lock, and the skin comes off. Now there's a stat lock missing skin underneath it. You know what I mean? So I think I try to blame somebody else, but I'm sure it was me that did it.
We always try to. But then I think, Jack, back to your original point you made earlier about really poorly inserted lines, that's part of the issue we have with some of our dressings, that we have to tack them down so much because they're pointing towards the sky. But
that is the problem. To me, that is the problem. And then you get to, well, look, the care and maintenance, the bacteria came on day 5, like that. It's all related. It's all related. It starts like, and I say, if you want to fix the problems in your institution, fix insertion first. I listened. I was at the INS. In June, and there's a lady from Providence system in the Northwest, Becca Bartles, and she's an epidemiologist, PhD, and they have a SWAT team. So they have a 54 hospital system, and they would send the SWAT team, which is like 4 or 5 nurses, 4 or 5 infection preventionists, epidemiologists, to go to the hospital that had the worst record of CLABSI during COVID. And they had some really, pretty poor results. And they looked at stuff, and I was impressed at the stuff they look at. So stuff they looked at were like no clip form, education suffered. They went in the closets and saw that the supply closets were not standardized. They looked at, travelers, nurse to patient ratio. I mean, they looked at 50 things. And I said to her, look, I do the same kind of thing that you do. I go and look at what they're doing. I don't do it in your level of sophistication. Don't get me wrong. But I said, if you fix the supply closet, if you standardize the supply closet, but you didn't fix insertion, I'm sorry, the clip form, hey, fix it. Like, in other words, all those things, they're not equal. They don't have equal importance. You know me, I can get my point across when I get you on the phone. They haven't brought me into Providence yet, but the 50 things she was talking about, they're not all of equal import. Like, fix insertion first. Like, if you got a doctor that knows how to put in a line properly, great. Those are that goes a long way toward preventing an infection. You know what I mean? Like, do the clip, do the nurse patient ratio, do all that stuff. But if you don't fix the insertion, I don't see how you get your bang for your buck.
So, Jack, I don't disagree with you. I mean, if you don't do a proper insertion, nothing else matters, right? Any of the
it matters, but measures, it matters. Not that it doesn't matter. It's that it's not. I don't like your phrasing.
So noted. However, a completely botched insertion cannot be fixed with optimal care and maintenance. That's all.
No, exactly. Yes. Well said.
I think we're on the same team here. But I also think you and I are both big proponents of shoe leather epidemiology, bedside rounding, going to the Gemba, whatever you want to call it, because while I would agree with the things you said are pretty universal when we go out and we round at the bedside, I really hope that folks listening to this take the time to go and learn what is going on in their organizations with their staff, because the staff they have today may not be the staff they had 6 months ago, let alone the staff they had 4 years ago. And the practices that have crept in over the last 3 years, making assumptions because this is what we always find. I just really hope that the education and the interventions that are taking place are being driven by what's really happening today in the organizations. And you can't get that from a chart review, and you can't get that from asking a manager or a vice president. It's observing the episodes of care while they happen, which is fun.
Back to point number one. If you have a strong like director, his main job is to do the training. his main job he has to be, become an expert at vascular access, but he has to train the people. Like these things get filtered out by having somebody that's in charge that knows what they're talking about, or it has the potential to get filtered out.
To your point too, though, that director, whoever's doing the training, has to be an expert, because if I deem you competent, and I'm an expert, that's one thing, but you're someone that has limited experience saying someone else is competent, right. You're never going to get where you want to go.
Well, but
to that point, I'm just going to, because you're pushing my buttons. To that point, there are many people in the country that have the title Director of Vascular Access, but it's the fifth duty. Number one, they do a little general surgery, they do a little trauma, do some critical care, do like IV nutrition. And oh, by the way, you're the Director of Vascular Access. You know what I mean? Like they don't like for me, I was Director of Vascular Access and I did other things when I had availability after that. But there are a lot of people that have this title. Maybe they get a small stipend, but they're not truly a modern Director of Vascular Access.
So
I was just going to echo what you were saying about, and I think it was in the previous version of the standards. I think it's still there, that the people doing competencies need to be competent themselves. Yes. And I think as we look at what's going on in our organizations today, that is not only not always, but often not the case, that these are assumed or presumed to be just basic skills that everyone has. And we know that they're not. So looking at our initial competency processes and looking at our ongoing competencies, which have to be driven by understanding the quality improvement needs of the organization. It's not just going back and changing a dressing again, if that's not what's leading your failures or your complications. So establishing that baseline competency and ensuring that the rubrics and all the training and all the observations are actually valid and signed off by someone who has the skill set to do it.
And that's ACE by Ava. Look at us. We're promoting our own product, which is assessing competency by expert. You know, Shelley and Jack, there's a huge difference between being competent and being an expert in this procedure. You know, there's so much. And then right back to the first thing that I wanted to talk about was really about dressings and dressing adherence, that I know we've gone around the entire mulberry bush, as it would be, but experts in our field when you have a patient they're allergic to adhesives and you can't use your traditional dressings, or they have skin breakdown already, or they're a burn patient or whatever, there's a lot of quivers that we can go to. We can pull out a new arrow anytime and shoot with that. They don't immerse themselves in vascular access. They don't think down an algorithm of options. Like if I've had a patient that was allergic to everything. I couldn't use CHG. He was allergic to the adhesive dressings. And I found a dressing that actually worked for him, that I could actually use an adhesive base, silicone base dressing, real gentle. That was down the algorithm. It was my traditional dressing. Then it was the IV 3000. And then I went down to another high level dressing. Those are the things that, we talk about what expertise and experts can do, that even though it's not inserting the line, it's maintaining or helping to care for that line. And those are the thought processes that we need to be able to have. Hey guys, we're going to take another quick break and hear from our sponsor today, from Covalon. Are you tired of cringeworthy dressing removals? Your patients are already going through a lot, and so are you. Protecting vascular access sites does not need to be painful. IV Clear is the world's only dual antimicrobial clear silicone securement dressing. Dual antimicrobials in this gentle silicone adhesive dressing offer infection prevention throughout the entire surface of the dressing while protecting your patient's skin integrity. Take the pain out of dressing changes, heal without hurt, and try IV Clear for yourself today. Learn more at covalon.com/gentle. Again, covalon.com/gentle. And if you're at this year's AVA conference, stop on by at booth 607. Now, let's go back to the show. Jack, is there something else you want to add to this?
I don't have much to say, beyond. I don't have much to say on this point. I do have another point I want to bring up.
Please do.
It's very clear, based on common sense, motion, that the chest is the best exit site for these catheters. It's really not disputed that that's where these catheters belong. There are 3 ways to do it. Number one is puncture vein on the chest. When you use ultrasound, the name of that vein is the axillary vein. Why don't people, critical cares and others, use the chest site?
It's a deeper, steeper approach oftentimes, and they don't know it's there. They think they've learned all their life.
So they're scared of pneumothorax.
Yeah, they are.
Yeah.
And it's not as easy as the superficial IJ.
No. It's not as easy until you learn how to do it. And then it becomes pretty easy. Why are people scared of pneumothorax? Like, if you compare, like, CLABSI, the mortality is 12 to 25% in all the studies. Pneumothorax does not compare to CLABSI as a medical issue. Why are people scared of CLABSI? Why are inserters why are they scared
of pneumos?
Pneumos. Why are they scared? Thank you. Why are they scared of pneumos? I'll tell you.
They don't want to drop a lung, and it's embarrassing. Probably.
The pneumo is the drop lung. Embarrassing. It's attributable to them.
Absolutely.
Like the CLABSI, hey, anesthesia wasn't me. There's no ducking. They're scared. It's attributable to them. So
True.
they're not going to do it. I mean, and another thing is, if you know how to put in a chest tube, why should you be scared of pneumothorax? I mean, people are scared of the wrong thing. They should be scared of CLABSI, but they're scared of pneumothorax. Next thing, they're putting up in the neck with a dressing on the mandible. I have one patient with a dressing on the earlobe. I'm going to show it at this year's AVA conference. And it's a perfect dressing. If I ever have a central line and I need a dressing on my earlobe, I want that person to do it. There's no pleat. It goes around to the front, to the back. It's perfect. The dressing's on the earlobe. I'm sorry that, there's more wrong with it than that, but,
the ironic thing about going axillary is you can actually see the lung and the vein at the same time, and you don't. I mean, there's clearance. You've got room. It's just craziness why people are pushing against axillary or don't know about it. Well, guys, this has been amazing. I can't wait to see you at Minneapolis Convention Center for AVA Scientific Meeting. Thank you so much for being here today.
Always a pleasure, Judy. Thanks so much for the invitation.
My pleasure. Everybody, test for COVID before you come. None of us want it. Bye, y'all. Can't wait to see you in Minneapolis. Travel safe, everybody.
You.
We appreciate things so much.
We love the work you do, Judy.
Yeah, always,
Thanks,
Judy. Thank you so much.
Thank
All
you.
right.
Super fun.
Bye.
You can see the entire AVA calendar on the AVA website at www.avainfo.org, which is also where you can join AVA or donate to the AVA Foundation. Don't miss Facebook Fridays, where we are live at noon Eastern Time each week. Toss us a question or give us a like. We're on all the social media platforms. You can follow the Association for Vascular Access on LinkedIn, Facebook, Instagram, Twitter, and Pinterest. Make sure you're subscribed to the I Save That podcast on iTunes, Spotify, SoundCloud, Stitcher, iHeartRadio, Pandora, or Google Play Music. Now here comes the legal stuff. The topics discussed on the I Save That podcast are purely for informational purposes. You should personally seek the guidance of clinicians before making any decision that affects your health or the health of your patients. Listeners of this podcast are advised to do their own due diligence when it comes to making vascular access decisions. Our goal is to inform and entertain the healthcare landscape while giving you a starting point for your discussions with your own clinicians and professional advisors. By listening to this podcast, you agree that the host, our guests, our sponsors, and the Association for Vascular Access are not responsible for the success or failure of your health, your career, or any decision you make related to any information we've presented. The I Save That podcast contains segments of copyrighted music that was not specifically authorized to be used, but is protected by federal law and the Fair Use Doctrine as cited in Section 107 of the U.S. Copyright Act. If you have any specific concerns, about this broadcast or our position on fair use defense, please contact us at podcast@avainfo.org. No part of this broadcast shall be reproduced, transmitted, or sold in whole or in part or in any form without the prior written consent of the Association for Vascular Access.